Welcome to the University of Miami's Institute for Advanced Study of the Americas. We're here representing the Lancet Commission on Global Access to Palliative Care and Pain Relief, and to present the study that we've published in the Lancet as part of this commission. In this presentation, the title of our report, Alleviating the Access Abyss in Palliative Care and Pain Relief, an imperative of universal health coverage. We're thrilled to be partnering with a number of institutions on this and individuals. Our report includes 61 co-authors, approximately 35 commissioners, and we worked hand in hand with Harvard's T.H. Chan School of Public Health and with the Harvard Global Equity Initiative, as well as at our own university with our Miller School of Medicine, in Mexico with the Mexican Health Foundation and Tomatelo Pecho, and with our implementation partner, the International Association for Hospice and Palliative Care. Let me start with what motivated me to chair this commission in 3 years of work. In this photo, I'm almost 18 years of age. I'm at my high school prom, and before going to that prom, I went to visit my father in Mount Sinai Hospital on the 17th floor. Only a very few weeks later, I would be with him as he agonized in the last days of life, dying of stomach cancer. Those last days were terrible, and he was in pain. I repeatedly requested access to more morphine or something to relieve his agony. As he squeezed my hand, he could no longer speak, and told me that he needed more pain relief. Yet at that time, in the early 80s, the question that the young physicians posed to me was that it might actually bring upon his death a few hours earlier than what it would have been naturally. I continued to beg, and eventually the medication was left, and a few hours later, after giving that to him, he died a somewhat more peaceful death. Since then, I've always asked myself, what would I have done that night as he agonized had I not had access to that medicine? Would I have had to do something that I truly would have regretted for the rest of my life, rather than helping him to be able to die in peace and without pain? All my life I lived with that, thinking it through and realizing eventually that the vast majority of the world lives exactly in that situation. This is how our report begins. We ask you to think about the following. Imagine your final months, weeks, and days of life. Like most, you probably hope to be free of pain. Consider, however, a different scenario, one in which you and those who hold you dear face those painful days, those days that I was with my father, but with no access to the palliative care that could alleviate your suffering. This is Tolstoy's Ivan Ilyich, bereft of even opium to calm the fear and the agony. Is this unimaginable? Yes. Yet this is the reality for most people. With very few exceptions, poor people throughout the world live and die in pain and without access to palliative care. That is why we open our report with the quote from Leo Tolstoy, The Death of Ivan Ilyich, written in 1886. And Tolstoy wrote, from that moment commenced the shrieking fit, which lasted for 3 days and was so terrible that it was impossible to hear it without horror, even through 2 doors. Our Lancet Commission Report, the product again of 3 long years of work, was led by Harvard University and the University of Miami for the Lancet. It is a diagonal approach where we brought together palliative care specialists and specialists on health systems and global health. I chaired that commission, proud to have done so with my co-chair, Dr. Paul Farmer from the Harvard Medical School and Harvard University, with 33 other commissioners, and with 61 co-authors representing 25 countries from around the world. This is what we came up with. 5 key messages summarize the work in that report. First, that alleviation of the burden of serious health-related suffering from life-threatening or life-limiting conditions and at end of life is a global health and equity imperative. Second, universal access to an affordable, essential package of palliative care can alleviate much of the burden of serious health-related suffering. Low and middle income countries can improve the welfare of poor people at modest cost by publicly financing this essential package of palliative care and through full integration of the package as part of universal health coverage. 4, international and balanced collective action is essential to achieving universal coverage of palliative care and pain relief by facilitating effective access to essential medicines while implementing measures to prevent non-medical use. And finally, our point 5, better evidence and priority setting tools must be generated to adequately measure the global need for palliative care, to implement policies and programs, and to monitor progress towards alleviating the burden of pain and other serious health-related suffering. The presentation, which summarizes approximately 30,000 words of work, begins with an analysis of what is need globally, our measure of serious health-related suffering. Second, we'll talk about unmet need, both in terms of level and equity. Then, what is the intervention that we're proposing, this essential package? The fourth part talks about strengthening the global and national health systems. And finally, we'll briefly go through one implementation example from Mexico. In our report, we have dozens of examples from countries around the world that are successfully closing the pain divide. First, we'll give you a brief overview and introduction to the measure that we developed, called Serious Health-Related Suffering. We describe this in the presentation using the acronym SHS. Serious health-related suffering is derived from mortality data for the conditions that most generate a need for palliative care and pain relief. In this case, we look at 20 major health conditions. We look at both number of patients in need as well as the days of accumulated suffering that patients have around the world. And you can see this elaborated basically in these pie charts. We looked both at individuals who die in the year that we considered in 2015, as well as those who lived with a major and difficult health condition that would have required access to palliative care and pain relief, but did not die in that year. Overall, we find over 25 million people every year who die with serious health-related suffering, another 35.5 million who don't die, non-descendants, who also have serious health-related suffering, and a total of just over 61 million people. You can see this in terms of patients or in terms of days, almost 12 billion days for descendants, 9 billion days for non-descendants, and just over 21 billion days when we think about each kind of suffering across each patient. I told you that serious health-related suffering is based on 20 kinds of health conditions that are listed there. We also looked across 14 different types of suffering. Physical symptoms, 11, and psychological symptoms, 4. And much of this data was collected and derived with very hard work by our palliative care experts, led by Dr. Eric Krakauer from the Harvard Medical School. You can go into this database with us and through the report, and then divide up and analyze by health condition as well as across patients and across days and type of suffering. In summary, our global burden of serious health-related suffering for 2015. We identify 25.5 million deaths that required palliative care. That's 45% of the 56.2 million deaths worldwide that year. And in addition, at least, and much more difficult to measure, the 35.5 million people who experienced serious health-related suffering and did not die in that year. We refer to them non-descendants. That gives you a total of 61.1 million people worldwide who suffered and required palliative care, and without looking at these cumulatively, but rather the absolute number of days, our minimum estimate of over 6 billion days of suffering and up to 21 billion days of suffering. This is a huge burden. The next step in this work, one that we hope to push forward very soon with partners from around the world, is to begin to dig deeper into how to measure serious health-related suffering and develop this into a measure of progress across countries. Not all of this suffering remains unattended through palliative care. Some people do have access. Our best estimate is that about 80% of this burden happens in low and middle income countries around the world. And these are the countries that have the weakest and least coverage of health services and very little access to palliative care. Let's look at this for a country. Again, our case study here, the case of Mexico. The burden of serious health-related suffering for Mexico is just under 500,000 people per year. 230,000 deaths, which are 37% of all deaths, 240,000 patients or non-decedents, and that makes up 150 million days. Given that this is an upper middle income country, most of this need for palliative care is concentrated in cancer, HIV/AIDS, injuries, dementia, liver, and lung diseases. Now let's look at how much of this is unmet need. What is our best estimate of what proportion of those 61.1 million people with serious health-related suffering actually have access or do not have access to palliative care? We summarize this need, and throughout the report we do this with case studies. Would our palliative care experts, in this case Dr. Rajagopal from Kerala, India, can tell us about how human beings live through palliative care and pain without access often to even the basics. Dr. Rajagopal writes of his experience with Mr. S. In agonizing, crippling pain from lung cancer, Mr. S came to the palliative care service in Calicut, Kerala, from an adjoining district a couple of hours away. He traveled by bus. Mr. S's body language revealed the depth of his suffering. We put, Dr. Rajagopal and his team, Mr. S on morphine, among other things. Only a couple of hours later, he surveyed himself with disbelief. He had neither hoped nor conceived of the possibility that this kind of relief was possible. Mr. S returned the next month. Yet common tragedy befell patient and caregivers in the form of a stockout of morphine. Mr. S then told Dr. Rajagopal and his team, with outward calm, "I shall come again next Wednesday. I will bring a piece of rope with me. If the tablets are still not here, I am going to hang myself from that tree." He pointed to the window, and Dr. Rajagopal is sure that he meant what he said. Stockouts are no longer a problem for palliative care in Kerala, and this is very much thanks to the work of Dr. Rajagopal and his team. But throughout most of the rest of India, and indeed our world, we find near total lack of access to morphine to alleviate pain and suffering. As I said, we are going to look at the world's unmet need for palliative care and pain relief. We use pain relief as a tracer because we are able to identify what is and is not available in countries using data from the INCB, the International Narcotics Control Board. We measure this in terms of what we call DOME, distributed opioid morphine equivalent. So we measure in terms of the most basic. Oral tablets, off-patent, inexpensive, basic medication, and injectable morphine. In this slide, we summarize the inequity of access to opioid analgesics in our world. We know, through the data that we present in our Lancet report, that the 50% poorest inhabitants of our world have only 1% of the world's opioid analgesics measured in terms of morphine. The 10% richest have almost 90% of what is distributed in our world. Less than 1% compared to almost 90%. This is one of the most inequitable, if not the most inequitable distribution that the 35 commissioners in hundreds of accumulated years of public health experience had ever seen. We looked at both total medical need using Western Europe, high-income countries as our benchmark, what they consume in DOME, as well as palliative care unmet need. Palliative care unmet need is measured in terms of serious health-related suffering. So what you are looking at in these statistics is the ratio between DOME, distributed opioid morphine equivalent, and either days of need of pain relief, of morphine, in terms of serious health-related suffering, or in the case of the larger pie, you're looking at total medical need using what Western Europe high-income countries consume as the benchmark. Look first at this pie. Total need is 82 tons. Unmet need in our world, 49 tons. High-income countries have more than what they need in many cases, and the rest of the world is almost empty, particularly low-income countries. If we look at total medical need, 581 metric tons according to this measure, unmet need is 548 metric tons, and almost the entire circle is blank because we don't have this in our world. We mapped distributed opioid morphine equivalent, or DOME, compared to serious health-related suffering around the world. The map that you see in front of you does not show miles or kilometers squared. It shows how much basic morphine is available compared to palliative care need through serious health-related suffering. Look at this map. It's gone around the world. The Lancet focused on this image in particular. What you see, what you should see, and what you should focus on is how most of our world disappears. Latin America and the Caribbean. Here, a tiny slice is India. All of Africa contained in this small proportion. China and Russia fade into almost nothing. Europe, we see that as our benchmark, about the size it should be, and an engorged Canada, USA, and Australia. The focus of our report is on the pain crisis, the part of the world that disappears, not the opioid epidemic, which is the other side of the coin that we discuss later in the report and later in the presentation in terms of lessons learned for health systems. Important also to signal that just because all of this medication is available in these countries doesn't mean that patients actually get what they need or what they should have. Let's summarize access to pain relief in the country that we're sharing with you in this presentation, Mexico. 562 milligrams per patient with serious health-related suffering in need of palliative care, compared to an average requirement of 1,561 milligrams. This means that at least 64%, 2/3 of palliative care need, not even thinking of other needs, just palliative care need, must go unmet, and puts Mexico, in terms of ranking across countries, at number 64 out of 172. All of those other countries taper down to something close to zero access. The estimate to meet total medical need for pain relief is over 13,000 milligrams per patient, meaning that with current stocks, Mexico cannot even meet 5% of medical needs for pain relief. Now let's share the intervention that our commission proposes, the essential package. We did this work based on what Disease Control Priorities 3, also published in 2017, developed as a methodology. And we included our package in part of what the Disease Control Priorities Group considers essential universal health coverage. Let's look at our solution, the essential package, developed by a group of experts from around the world, palliative care experts, led by Dr. Eric Krakauer, as I mentioned, of Harvard Medical School. The intervention includes basic off-patent medicines that are part of WHO's essential medicines list, basic medical equipment, thought through using frugal innovation, and a package of human resources that are necessary to be able to make this package, this essential package, available at any level of the healthcare system, from primary up to tertiary. We align our recommendations for universal access to this package of care with the Sustainable Development Goals, the SDGs, saying that this must be made universally accessible by all countries by 2030. Let me highlight for you the core, morphine. In this case, we are speaking again only about off-patent, inexpensive medicines. This is oral, immediately released morphine tablets and injectable morphine. And we did think through this package for adults as well as children, although a next step is to have a child-specific package, thinking of oral morphine as needed for children. We costed out our package for specific countries and around the world. This is the case of Mexico. The cost per patient in total in US dollars. We looked at reported prices for medicines with a strong focus on morphine, and compared that to international prices, the lowest that we could identify in international databases. For many countries, we saw a very important difference, a tremendous heterogeneity in prices, which leads us to a strong conclusion in our report about the need for aggregated financing platforms to help countries to be able to access medicines at better prices. In this case, the problem, shall we say, in the Mexico case, is injectable morphine, which is being purchased at a much higher price than we can find in our international databases. But even at those prices, as a percent of public expenditure on health, this basic package, which is too basic for a country like Mexico, which is an upper middle income country, but this is less than 1%. And at best international prices, 0.84% of public expenditure on health, a tiny proportion. We also compared the cost of our package to the DCP-3 Essential Universal Health Coverage package, and our package is approximately, the palliative care and pain relief package, approximately 3% of that overall universal health coverage essential package. This is a very small ask to be able to close a huge global divide. We focused particularly on closing the pain divide. First, because we had a good measure, good data on access to opioid analgesics through the International Narcotics Control Board database, but also because this is such an important tracer of need for palliative care. We, as I showed in the Mexican case, we compared the prices that countries pay to the lowest international prices around the world. We find that at current prices, the cost of closing the entire pain divide, the global gap in access to opioid analgesics, measured and thinking in terms of immediately released oral morphine and injectable morphine, is $600 million. At best international prices, it is only $145 million per year. To put this in some context, this is about the cost of a medium-sized county hospital in any high-income country around the world. We also looked at the case of children, and this is one of the pieces of data that most moved us. To close the pain divide for all children with serious health-related suffering in all of the low-income countries of our world, and almost all of those children have almost no access. The total cost, at best prices, is just over $1 million per year. Now let's talk about how to strengthen the global and national health systems to be able to meet this very affordable need, at least through the essential package. I spoke with you a little bit about some of the global solutions. For example, we talked about the need to have a financing platform to aggregate demand across countries so that they could achieve better prices for these key medicines. But better prices and giving them medicines isn't going to solve the need for palliative care unless health systems can be strengthened to be able to ensure that these medicines and essential services reach patients in effective ways. Therefore, our report talks about how each function of the healthcare system needs to be strengthened in order to have countries offer universal access to pain relief and palliative care. These are key changes that are required in addition to what's required to strengthen health systems to achieve universal health coverage. We talked about stewardship, financing, delivery, resource generation, and information and research, all of the key building blocks and functions of health systems. As an example, in the case of stewardship, we talk about the need for national plans for palliative care and pain relief, which are absent in almost all countries around the world. In our report and the research that we did, we focused a lot on opiophobia, the fear around the world that increasing access to opioid analgesic medicines to solve the pain divide could create some kind of an epidemic of abuse or addiction. While these are extremely serious issues, when we focused on the policy recommendations analyzing the US case, we see that there are clear lessons for health systems to be able to avoid the risk of seeing what's happened in the United States, and at the same time, to be able to guarantee the populations that require them, the patients that need them, access to pain relief. We developed a set of recommendations that we feel are absolutely essential. First, countries must monitor both the supply and marketing of opioids. Second, prevent and eliminate, make it illegal to direct market opioid medications to healthcare providers through pharmaceutical companies. Third, ensure that all health personnel receive mandatory basic training for safe management of opioid analgesics. And four, ensure that indications for use and prescription of opioid medicines follow evidence-based practice. This is the way to avoid what we're seeing today in the United States, the opioid epidemic, which we identify as a very unique and very upsetting and a situation that could have been avoided. The fact that we have over 60,000 deaths per year in the United States from opioid overdoses. We align with the recommendations of the World Health Organization, of the International Narcotics Control Board, and of leading institutions from around the world in calling for a balanced approach. A good, balanced public health approach means ensuring that opioid epidemics are prevented and at the same time that patients have access to necessary pain relief. It means paying attention to both medical needs of all patients as well as the public health risks of non-medical use. Now let's look at our implementation example, the Mexico case, a case that I know well, the country that I call home, and where I've been working for about 5 years on improving access to pain relief and palliative care. Universal health coverage in Mexico has been hailed as a global example of how UHC can be achieved. And in a series in the Lancet, we published Mexico reached a truly immense landmark in its pioneering journey of health reform, achieving UHC for its 100 million citizens. Mexico has showed how UHC, as well as being ethically the right thing to do, is the smart thing to do. Health reform done properly boosts economic development. And finally, we celebrated success and hope for a sustained Mexican wave of UHC worldwide. This was in a series published and then a follow-up article in the Lancet in 2012. Shortly after this was published, I realized that the majority of Mexicans did not have access to palliative care or even the basics of pain relief. I recognized this when I visited this patient in the Regional Hospital of Ciudad Guzman in Jalisco, Mexico in 2012. Let's call her Doña Rosa. Doña Rosa was in the last stages of breast cancer, the same disease that I had battled only a few years before. Doña Rosa was obese, and Doña Rosa had brain metastases. We arrived there thinking we were going to help her to have access to chemotherapy as part of the Seguro Popular, giving universal coverage to women and others with cancer to necessary medicines. When we came in and realized that what Doña Rosa needed was palliative care and explained this to the hospital, the reaction was impressive. They said, send her to the capital city, to Guadalajara. Her children around us at the time were shocked. They could barely move her, and they didn't have the funds to even pay for a bus, much less for a taxi or private car to take her hours away to the capital city and another major hospital. And the question I had to ask myself, and Doña Rosa was actually not in pain, was why couldn't one of our secondary level hospitals offer palliative care? And the answer was that it really wasn't included in the package of covered services. It had been overlooked, as is the case for countries around the world. Based from the Mexican Health Foundation, we put together an analytic team to look at why palliative care and pain relief were not part of what had been achieved for universal health coverage. It's 2013 at this point, and we review what exists. We identified that there was very innovative legislation that had been put through, a good framework, approved in 2009 as part of the General Health Law and then updated in 2013. But we quickly learned that while legislation is necessary, it is not sufficient. And although it was essential to solve this and to be able to further legislate and apply the laws that had been put in place, put them into action, legislation had been ignored. Advocacy played a truly key role in evoking policy and legislative breakthroughs. We put together an interinstitutional working group, again, based at the Mexican Health Foundation. We worked with government. We worked very closely with Human Rights Watch that had undertaken an in-depth and excellent report on what was missing in Mexico. We worked with civil society, those who worked on cancer and those who worked on other diseases. We worked with the few in the country that were working on palliative care, including our National Cancer Institute. This advocacy by a large group of local NGOs in collaboration with the Supreme Court judge, a Minister of Health, and organizations like Human Rights Watch drove policy change. Many things have changed since we first looked at what was missing. For example, the law was enacted through the Ministry of Health, which means that it was implemented throughout the country. What we called norms were developed and applied. Second, palliative care and pain relief services were included in the Seguro Popular's essential package. And third, a huge changeover. Electronic prescribing replaced paper prescribing for controlled substances, and this was a major legislative and institutional shift on the part of the agency that manages risks associated with food and drugs, the COFEPRIS. With the launch of our report of the Lancet Commission on Global Access to Palliative Care and Pain Relief, we were able to push forward even more change in Mexico. The next step is a National Palliative Care and Pain Relief Association that's in the process of being established. It's an interinstitutional, multidisciplinary national committee to advocate for implementation and to monitor commitments, compliance, and progress. The launch in Mexico of the report of our Lancet Commission on Global Access to Palliative Care and Pain Relief provided an opportunity to get this work to push forward one more step. And the next step is to establish a National Palliative Care and Pain Relief Association. This interinstitutional, multidisciplinary national committee should advocate for implementation, monitor commitments, compliance, and progress, and it is in process, becoming established. One of the problems that this committee needs to work on in tandem with government is that we know, based on surveys, that less than 15% of medical and nursing programs at universities around the country include palliative care or pain relief courses. The task that this sort of a committee will have is to work to press universities to develop the courses and build awareness around training institutes to include palliative care and pain relief for all as part of primary care. This includes doctors, nurses, social workers, clergy, and all others who are going to be providing access to palliative care and pain relief. Our Lancet report was accompanied by a brilliant editorial written by the editor-in-chief of the Lancet, Dr. Richard Horton. Dr. Horton said that this is a milestone for palliative care and pain relief, and he called us to action. He said that measures of suffering have been absent, and so the need for palliative care and pain relief services had been easy to miss. That excuse no longer holds. The scale of human suffering is massive, and the Commission has uncovered an appalling oversight in global health. It is time for that oversight to be remedied. We are undertaking 4 streams of work following the report release: advocacy and awareness, research, global collective action, and in-country implementation. We've established a large implementation working group that includes the global associations, the regional palliative care associations, and several of the national associations for the largest countries. This work is anchored by the International Association for Hospice and Palliative Care by my colleague, Dr. Liliana de Lima. In collaboration with the other organizations, we're undertaking a series of activities. First, to develop monitoring frameworks and public accountability tools, including data, indicators, and targets for use by national, regional, and global governance institutions, including, for example, the International Narcotics Control Board. Second, to support the creation of national commissions through training and capacity building, and to engage in national planning. Third, to promote knowledge generation and exchange platforms to implement health system research results. And finally, to create multi-sectoral linkages between the palliative care community and the NCD movement, and therefore broaden development efforts and financing platforms. Let me conclude by sharing that through our implementation working group, in alliance with the International Association for Hospice and Palliative Care, and through the University of Miami's Institute for Advanced Study of the Americas and Miller School of Medicine, we are producing materials in a toolkit to assist civil society, government, and others who care about closing the gap in access to palliative care and pain control in our world to be able to use this report. You can access fact sheets, this video, of course, and other key materials at our website. Please write to us. Please share your concerns and the information that you have so that we can be part of a global movement to close the gap in access to palliative care and pain relief in our world. Thank you very much for sharing of your time and for listening to this video.